We have a big topic today. What's the difference between Alzheimer's and dementia, and why does this matter? I'm going to be covering a lot of ground, but really a major goal of mine is to help us all come up to speed on the many advances that have happened in the field of Alzheimer's disease specifically, which is also elevating our understanding of other causes of cognitive impairment and dementia with aging. And so I'm going to dive into that. Some of this is going to be a little sciencey, and so just bear with me. But I think we're all public and community is smarter than some of the information we're getting. And so this is so important to getting good care and support and resources and treatment. Our objectives today, so getting up to speed on our current understanding. I'm going to focus on Alzheimer's disease today. Other talks in the future we'll talk about other causes of dementia, such as Lewy body disease, that alone is a huge topic. And then how can this knowledge help you and your family members in your community get access to the right clinical care, treatment, resources, and support? It's always helpful to start with the numbers. In 2024, it is estimated that 7 million Americans are living with dementia and 50 million people worldwide. Now, this is coming from the Alzheimer's Association that has a great publication every year called Facts and Figures. Even here, though, I would just start by saying that the terms dementia and Alzheimer's are used interchangeably, leading to likely some inaccuracies. And so here, the numbers are really for dementia. We don't know if all of these people have Alzheimer's disease, but probably a large percentage of them do. And you can see here on the map of the US, the darker means they have higher prevalence of dementia, and those percentages, so for example, the darkest is 12 to 12.9%. That is of people who are older than 65 years old in those states. 12 to 12.9%, for example, in California, have dementia. Now, we know that over 50%, maybe even up to 2/3 of people who have dementia still are never diagnosed during life, and we'll touch on why that is. Huge costs, of course, $36 billion for Alzheimer's disease and related dementia costs overall, just in the US last year. Greater than 11 million Americans provide unpaid care for persons with Alzheimer's. And the lifetime risk for Alzheimer's at age 45 is 1 out of 5 for women and 1 out of 10 for men. I personally need to simplify things a lot to really understand them. The very basic simplification of what is the difference between dementia and Alzheimer's disease is that dementia describes symptoms or a cluster of symptoms, which we generally call a syndrome. Whereas Alzheimer's disease describes the underlying cause of that disease. What is the pathophysiology in the body, or the etiology, as we commonly refer to it as healthcare professionals? I find it helpful to analogize this to a common symptom that people may experience. I mentioned dementia was describing symptoms. Another symptom someone may have is knee pain. Now, if you go to your doctor and you say you have knee pain, or your healthcare professional, they're going to undertake a variety of questions and physical exam techniques and tests and imaging potentially to try to get to the bottom of this. Here's a short list of the many possible causes of knee pain. Now, if you go to your doctor and you say you have knee pain, probably you're not going to be happy if they just say your diagnosis is knee pain and here's some over-the-counter pain medication, because it's not getting at the root cause. You know, it's not going to fix the problem, and it will probably maybe persist and get worse. Now, unfortunately, still with dementia, the symptoms and syndrome of dementia, this still happens, but this is changing rapidly given our advances. Dementia describes symptoms or a cluster of symptoms such as we call a syndrome. Now, all of these words are really important in the definition of dementia. Dementia is a slowly progressive change. This is occurring over years in thinking and often mood. Now, when you have change in your thinking that happens over seconds, minutes, hours, days only, that is not dementia if something happens that suddenly. That would be a whole other potential list of things that the healthcare team will need to figure out. Here are just some common areas that are affected with these slow changes in thinking over years. That could be, of course, short-term memory, word finding, trouble organizing, visual spatial difficulties, and also neuropsychiatric symptoms are common and often under-recognized as a common feature even early on in dementia, namely depression, anxiety, and irritability. And I'll just add as a side note, since I'm a psychiatrist, there is more of an understanding that some of the psychiatric symptoms in different causes of dementia, like Alzheimer's disease, are actually related to the changes in the brain directly, say causing depression symptoms and anxiety symptoms, and not just a reaction to the external challenges of living in the world with progressive decline in thinking. First, we have the changes, slow changes over years in mood and thinking, and sometimes mood. And then number 2 is slowly progressive decline in functional abilities. This will start out, of course, with higher level complex tasks, for example, managing job responsibilities, finances, medication, driving. And then as things progress, less demanding tasks become more challenging, and there can be confusion about people, time, and space, for example, amongst many other things that can become more difficult. And then finally, as causes of dementia progress, self-care tasks are impacted, where a person needs help with bathing, feeding, things like that. And so to have a diagnosis of dementia or be told you have the symptoms of or syndrome of dementia, you must have both 1 and 2. Now, dementia is typically further categorized as mild, moderate, or severe. In fact, most healthcare professionals, I would say, don't necessarily clearly explain this to families or determine this. And this is largely because there just isn't time in a visit, say with a primary care provider, to really get to the bottom of this. It takes a lot of time of asking questions of both the person with the cognitive impairment and the family members often to figure out if they're in the mild, moderate, or severe stage, especially if you don't know them very well. And it's really not reimbursed yet by payers to take the time to figure this out. Now, I hope that I elucidate in this talk why it's so important. This is crucial to know the stage of your person who has dementia to really help direct them to the right treatment, care, support, and resources, and to help them be safe and to live as independently as they can be given their stage. Now, mild dementia, this is very, very broad what I'm saying, so requires some mild assistance with daily function. The person may be able to live independently. Then moderate dementia requires a moderate amount of assistance. And this is the stage that often people can't live alone. As it progresses, that typically becomes unsafe. Severe dementia is when a person needs significant assistance with daily function, including self-care tasks, as I mentioned, and will require 24/7 supervision in some way. I wanted to share another example of how dementia is defined in terms of the staging of the severity of the symptoms. Now, patients would often, so I'm a memory specialist physician, and patients would often come to me and talk about the 7 stages of dementia. Now, as a specialist and as a neurologist and psychiatrist trained in this area, this isn't the categorization that I use, but this system is also known as the Global Deterioration Scale, or GDS scale, developed by Dr. Barry Reisberg. And this is used in a lot of settings and very helpful to try to convey to another healthcare professional or agency, say social support agency, that, okay, this person is a GDS of 5, for example. So that gives them an understanding of the level of care and support and skills that that person needs. The challenge is that this isn't a direct match to what I just said, the mild, moderate, or severe dementia. And so it becomes very confusing without having a common language. And ultimately, I'll talk about how that does impact care negatively. So this is another example of how scientists and Alzheimer's researchers categorize the stages of Alzheimer's dementia. I'm now moving to specifically Alzheimer's dementia, and I'll get into what Alzheimer's is in a moment. You can see here, I'm not going to go through all this, but the point is that this classification is really where the field is going in terms of driving research and treatments, such as pharmacologic treatments. We go from a stage of the first one is at risk or preclinical. Now we have this understanding that Alzheimer's changes in the brain start before there's any symptoms. And so we want to eventually be able to detect or identify these people early on and potentially start treatments, which those are under investigation right now, whether or not those are effective at slowing the progression of disease in the brain and symptomatically. Then moving into a little bit of symptoms, prodromal, mild cognitive impairment, stage 3, and then we have mild, moderate, and severe dementia called stage 4, 5, and 6. This is more of, as a dementia specialist physician, how I think of the disease, but yet a family will come in and say, well, they're, stage 5, but their stage 5 is maybe the global deterioration scale, and my stage 5 is this scale. So we're not speaking the same language, and that is certainly problematic. And this is my final description of the confusion about different scales. We have the GDS, which I mentioned, going from 1 to 7 on the left, and then CDR, which I won't go into detail, but this is clinical dementia rating scale. And this goes from 0 to 3. And this is a scale that's often used in clinical trials to determine if the person is the right stage to be eligible for treatment. And you can see that there's inconsistency in a lot of this. And so this really needs to change. And we all need to be a part of the solution. And that's why I'm bringing this up. Now, the impact of the lack of consistent terminology. So this can hinder discussions in primary care settings because there's just a lack of clarity on, well, what terminology do we need to use? How will that change management is how we think about it as healthcare providers. And is there really even time to try to get into the weeds with this to help people given our current healthcare system? This negatively impacts appropriate and efficient treatment, care, resources, and support, confusion, and then families become frustrated and then often may seek guidance from sources with variable credibility. Some of them might be fine and some of them not necessarily. So many reasons why we need to standardize and systematize this. All right, so now that we've talked about generally what dementia is, being symptoms or a syndrome of that we can see and examine in a human and hear from them and their family member about these changes happening. What are the possible causes of the dementia symptoms? There are many, many possible causes of dementia. This is an abbreviated list, but I just wanted to let you know. So when you bring you or your family member to your healthcare professional, this is how we start to narrow down or zone in on what could be the cause or causes. Now, I highlighted 2 boxes here in the pink color, and those are the most common causes that we see, specifically Alzheimer's disease being the most common cause of dementia in older adults, but there are many others, and hopefully future talks will get into a lot of these. Now, because Alzheimer's disease is the most common cause, and we have made the most advances in terms of our understanding of what's going on in the brain, and that has led to advances in diagnosis and treatment possibilities, I'm going to elaborate on this for you today. First, we have Dr. Alzheimer, who discovered Alzheimer's disease. First, he found interesting, and her presentation quite different, was August Dieter. This was in Germany, and he was a psychiatrist and was also a pathologist. Now you see, she was quite young. She was in her 50s when she developed symptoms of Alzheimer's disease, or these changes in her mood, and she became psychotic and had to leave her house and live in an inpatient psychiatric unit, which is where he met her. But he noticed that she kept saying things like, alluding to that she lost her memory, and she would keep repeating things. And it was a little different than the other patients in this psychiatric unit. Even though he moved to a different facility, he kept track of her and got permission when she died to look at her brain under autopsy by her husband. August Dieter's husband gave permission. And he looked at her brain under a microscope, and what he saw were these strange findings that he called amyloid plaques and these tau tangles. So these have come to be known as the hallmarks of Alzheimer's disease, and still remain a crucial part of our understanding. And controversially, some people feel like we're too much anchored in these things, but yet you'll see moving forward why they have understanding the role of these protein changes has been so crucial in our development of treatment possibilities. So when a person has both of these abnormal proteins building up in their brain with aging, often what we see here is that basically these damage the brain cells, the connections between the brain cells, and many other things. And then the brain essentially shrinks as the brain cells are dying. And so you can see the Alzheimer's brain on the right, and the symptomatic changes, while they vary by person to person, one of the typical features is, of course, the short-term recall, impairment, or the rapid forgetting, though that doesn't have to be present in everyone who has Alzheimer's disease progressing in their brain. So I'll just briefly touch on this, not to nerd out too much. Finding of these amyloid plaques that has been studied for many years now led to something called the amyloid cascade hypothesis. And so this protein, there's a protein amyloid that we're all producing in our brains, but we clear it normally. However, something goes awry, and we're still trying to figure out exactly what all the things are that lead to this getting misfolded and becoming toxic and sticky. So you can see in this figure here, the APP is the amyloid precursor protein, and then this changes to a monomer, and then the conformation changes to a dimer and oligomer. And as it's going through this is where going from dimer to oligomer, it's becoming more toxic and fibril to the amyloid plaque. These are all implicated in the pathology of Alzheimer's disease in different ways. And what we've learned is that amyloid starts building up 20 plus years before there's any symptoms in people who are going to go on to develop Alzheimer's disease symptoms, i.e. dementia. This has been a major treatment target in clinical trials and has led to, which I'll talk to about in a minute, approved medications. Now there's certainly controversies, and with this focusing on the amyloid cascade hypothesis. What we see is that there are people that are building up amyloid in their brain and say they live till 95, and we are able to look at their brains under autopsy, and they've been perfectly cognitively intact, normal, yet their brain is full of amyloid plaques. So the question is, why did they not develop Alzheimer's dementia symptoms while other people do who have this? And so then when these treatments are being studied, these anti-amyloid treatments, there's a lack of consistent benefit. There's much that we don't know. And so there's certainly resilience factors, and we're learning things. I will mention I did lead these trials that led to the approval of these medications. I did see benefits in people, and that's not the topic of this conversation. So I really like this graph just to go over, just so you all know generally what's been going on in this field of Alzheimer's disease from 1906 to, the present. And the top above the line with the years above the arrow, what we see is advances in diagnostic measures over the years, and then treatments. Now we have over 300 treatments that have been studied in Alzheimer's disease, and only a few that have been positive. Now, the red arrows point to the advances in diagnostic techniques. And so the first one was in the mid-90s, cerebrospinal fluid. So doing a spinal tap could actually accurately diagnose the Alzheimer's disease changes in the brain through a lumbar puncture, looking at the spinal fluid. Now, while I'm a big proponent that lumbar punctures, i.e. spinal taps, are safe in this setting and really provide a wealth of information, I'm sure that many of you are concerned or worried about doing that, though this still provides a crucial role in our diagnostic approach. Then we have amyloid imaging, tau imaging, the ability to detect amyloid in the brain via imaging through what's called a PET scan, which is a kind of CAT scan where a tracer is injected. And this has gotten quite accurate. You can see this has been studied for years now. And when we were when the amyloid PET really was integrated into Alzheimer's research, including clinical trials of treatments, it became clear that the people who in these trials who had a higher burden of amyloid building up progressed cognitively faster in terms of their dementia than people who didn't have elevated amyloid in their brains. And now that seems to us in the science and medical community like maybe obvious, but at that time it wasn't so clear how important amyloid was in its role in Alzheimer's disease. Tau imaging came online later in the mid 2010s, and that's really been crucial in seeing the interplay between these two abnormal proteins building up, and tau tangles start impacting the brain and aggregating closer to when symptoms start, which is important. And there's a lot to say about that there's not time for. Later, you see 2019 to 2022 blood tests, plasma biomarkers. There was a breakthrough designation for these. So these are not formally officially approved by the FDA yet, but they're seems to be, close. We're waiting to hear this year if they will be. And then you can see these three drugs were approved: aducanumab, lecanemab, and donanemab, which specifically target their anti-amyloid treatments. So they effectively normalize the amyloid levels in the brain while slowing the progression of the symptoms over the study period, which was 18 months, and then open label, usually 18 months after that. Now, aducanumab is not available anymore, but lecanemab and donanemab are. And the bottom below the arrow, I just wanted to mention that you are all aware of the changes in the diagnostic criteria for Alzheimer's, which have evolved from, and this goes back to the point of this conversation, they have evolved to focus on the biology, bringing in the biology. So being able to see, is there amyloid in the brain elevated? Is there tau? And that playing a crucial role in giving someone a diagnosis of Alzheimer's disease, versus previously, even up to prior to 2018, it really was more focused on the clinical symptoms. So you can see on the bottom, the red circles, clinically defined diagnosis, shifting to pathologically defined diagnosis. I find it helpful to analogize this to the field of cancer, and how in cancer in general, actual symptoms the person is having are not what's driving these personalized precision treatments they're getting that are targeting the molecular biology of the disease that's happening. And that's what's leading to these amazing advances and remission rates, and cancers that just, 10 years ago had a much poorer prognosis. It's sometimes said that the Alzheimer's field is like 30 to 50 years behind the cancer field. And this is just another graph to show over time. On the x-axis is the symptoms of dementia evolving over time compared to these changes on the y-axis of these biomarkers. So the reason that I'm bringing all this sciencey stuff to you is because I think it's so important for patients and families and people who aren't necessarily in the scientific research side to at least have a sense of how far along we are in our understanding of this disease. You can see that 20 years before symptoms start, the amyloid plaques, for those who are going to develop Alzheimer's dementia eventually, these plaques start accruing, and then they're really ramping up. The slope is very steep in this preclinical stage. This is before any symptoms. And then they plateau by the time symptoms start, which we call mild cognitive impairment. And then the tau starts increasing later, but closer to the timing of symptoms. And then the subsequent curves are related to the brain volume changing, where the short-term memory center is, the hippocampus. So that's when you see that shrinking. You're already into the disease symptoms when you can see these changes on MRI and then clinically with cognitive testing. I'm just going to touch on this so you're aware. If we look at the brains of people who die with dementia, most people have more than one pathology that could be impacting. So people with Alzheimer's disease, for example, 40% of those, they think about 40% also have Lewy body disease pathology in their brains. And there's a number of other things that could be going on. Of course, vascular disease, changes in the blood vessels, cerebrovascular disease, that's common as well. So there's a number of things that are going on here, and it's important for us to be aware of that, and as a clinician to keep that in mind. So I mentioned we have these now Alzheimer's, what I call precision medicine, these anti-amyloid therapies, and there's many more things on the horizon. This is a really exciting time to be in this field. I feel lucky that, my mentors who are now moving into retirement, they did all of the heavy lifting and revolutionized this field. Now we're getting to see positive trials. That's opening up more a window of hope, and people seem to be more willing to have the conversations together themselves, their families, their healthcare professionals. People are advocating for themselves more. People who are younger, people who are in midlife, they want to know, like, how can I prevent this? What can I do? So these medications are available, and there's a lot to be said about this. They're indicated for early symptomatic Alzheimer's disease specifically, so mild cognitive impairment and mild dementia. And it seems that in the near future, I'll have another talk specifically on these treatments. But it seems that the earlier these treatments are started, they appear to yield more benefits in slowing disease progression if a person has less disease burden. Now, there certainly are potential side effects, and that will be discussed in a later talk that hopefully you'll join. So this is just going back to this amyloid cascade hypothesis that I showed you, or amyloid cascade, where as the amyloid changes form, these drugs are targeting different parts of that. So they are quite different, though they're in the same class called the anti-amyloid monoclonal antibodies. There's a thought that in this field where we're all focused only on amyloid, or maybe amyloid and tau, but actually we know there's many, many, many things going on, and we're just at the tip of the iceberg. And so here's just to see, I'm sure many of you are aware of some of these things and have personal interest in these different areas. And certainly the future is going to be combination treatment, targeting many of these things simultaneously, just the way, say, in the cancer field, there's combination treatments, that's standard. Now, I wanted to touch on going back to why have the terms Alzheimer's and dementia been used interchangeably? There's been a focus historically on the symptoms and not the biology. And that's because we didn't have a way to detect the biological changes in the brain until really the amyloid PET came online for Alzheimer's disease. As clinicians, it was difficult to know. And we know that when we look at the brains at autopsy and we compare it to a clinical diagnosis, say without these advanced biological tests, biomarker tests, we know that clinicians are wrong a quarter to a half of the time, that we misdiagnose people with Alzheimer's disease that actually don't have Alzheimer's disease in their brain. They have other things going on. Sometimes it's neurodegenerative, like Lewy body, or vascular dementia. Sometimes those things aren't present at all. So the symptoms of different causes of dementia can really overlap and look similar, which is why it's such a game changer to be able to specifically identify the Alzheimer's changes in the brain. Because then if someone doesn't have the Alzheimer's, they don't have the Alzheimer's changes in the brain, then we can really focus on, well, okay, it's something else, and dig into that. Now, another area, I think another reason why clinicians haven't used these terms interchangeably is because there's some systems issues. So in our healthcare system, we haven't been historically reimbursed for the comprehensive care needed to really help people and their families who are living with dementia. And so when they say, well, there's nothing we can do, many families, I've been in a specialty memory center over the years working, and so we have more time to give that comprehensive support, but most clinicians don't. Most general neurologists, most primary care providers. And so I think that when they say there's nothing we can do, it's a matter of, in the system we're in and what's available and our ability to navigate and get reimbursed, there is very little available. And that is changing, and I'll touch on that in a minute. Now, therapeutic nihilism, so that's this there's nothing we can do mindset, which, besides what I just mentioned, that fits in also with, I would say, our anti-aging culture, which I mentioned in the last bullet. And there's a lot to say about that, which I'll save for another talk. Also, this is a term I just made up called medical pseudo-altruism. When clinicians will often normalize someone's memory loss, they'll say, oh, you're fine. I do the same thing. You're fine. Don't worry. It's their own I'd say it's their own personal fear as a clinician, they themselves, of getting these diseases, of feeling like they're not equipped to really know how to help someone. And by doing that, unfortunately, though it's well intended, it increases the stigma and makes people and families not bring it up when, even if it's progressing. That's invalidating, and that is changing, luckily. Then there's medical paternalism, where some clinicians may say, well, they personally don't think the treatments are helpful that are available. They're not going to even broach the subject. Then I touched on this. I think there's a collective dread, denial, and stigma that leads to us avoiding these difficult conversations. And this sense of only a cure will do. Like, I will only really wholeheartedly embrace this Alzheimer's research and advances when there's a cure. And people don't say that outright, but that's sort of what it feels like. And being in this field, of course, I'm biased and I'm very excited because it is a huge advance from where I'm standing. But if you're not directly in this field and say you're a primary care provider, the relative advancement maybe isn't as big. And there really is a desire that we can make even more of an impact quickly. And that's just not realistic. But what we have in terms of advances are important and really improving things. We have many diagnostic challenges in Alzheimer's disease. So this is another reason why these terms are conflated. 72% of primary care providers reported that they basically feel ill-equipped to manage people with cognitive impairment. And you can see that in this graph here, there's a number of reasons why. All right, so shifting to this last part, why does this matter? Why does it matter to know what the difference is between dementia and Alzheimer's disease, for example, for you or your loved ones or your patients and families? Knowledge is power. And if you know what you're dealing with, then you can take the steps to take control of your life for yourself and your family. You can make decisions that fit your goals and your values. You can get all the information. There's more ability to advocate, to get on the same page with your healthcare team, and to get all the information from credible sources. With this information, you can access disease-specific treatment. Currently, there are symptomatic treatments for various causes of dementia at all stages. And also, as mentioned, there's some Alzheimer's-specific disease-modifying treatments. And if we know this, we can get quicker care, more efficiently, save time, money, and better outcomes when we can get this information. So in my constant attempts to help elevate everyone's understanding of kind of where we're at in this field of Alzheimer's specifically, and not to be too confusing or overwhelm you. This is the latest iteration of the recommendations for diagnosing Alzheimer's disease. And so there's an attempt to develop a system to integrate the biological changes and the clinical changes. You can see the top row, we have the clinical stage 0 to 6. So that's similar to what I mentioned before, with 4, 5, and 6 being mild, moderate to severe dementia, basically. And then you see on the left side here, the biological stages, which I'm not going into detail about how they're categorizing that, but you can look in that Cliff Jack paper from last year if you really want to get into the nitty-gritty. And so someday soon, perhaps, a person, I'll diagnose someone with stage 4C Alzheimer's disease, for example, and that will direct personalized treatment and care and support. And I think that's really exciting. And that's similar to what's done in the cancer field. Now, I like to point out this caveat, the note on the bottom, that considerable individual variability exists in the population, and individuals who lie above the diagonal often have greater than average comorbid pathology, and below the diagonal better. They may have exceptional cognitive reserve or resilience. So these are these other factors that we're trying to understand, all of the different things going on in the brain. We know there's not just Alzheimer's, there's so many things, but this is such an important start. And another good thing that's happening is that Medicare and payers are now recognizing that they really need to reimburse for the care and support services and that's going to help everything. And ultimately, in the long term, we hope it will show decreased healthcare costs, but certainly with their aims here to focus on improving the quality of life for the person with dementia and their caregivers, delay avoidable long-term nursing home care, and able to remain at home through end of life, reduce caregiver strain. I mean, these are all wonderful things. And so what they did is it's essentially a demonstration project or program called Guiding an Improved Dementia Experience. And this is an 8-year demonstration program. They awarded last year, they announced the 400 awardees. These are different kinds of hospital systems, medical groups, home health agencies, dementia care navigation agencies that are doing a variety of these kinds of programs, tasks to help people, and they're able to bill Medicare and get reimbursed. Hopefully that'll lead to some more reimbursement for these other services. I like to, of course, take it back to the real world. If you're someone who's has someone for yourself or your loved one, or thinking about for the future. So I hope I gave a sense of how complicated this field is, and our understanding has evolved so much, but unfortunately, it is very confusing for even most healthcare providers, what is happening and what's available and what's accessible. I would just say the most important things are determine if dementia symptoms are present. So you want to ask the healthcare provider, the primary care probably, or the neurologist or psychiatrist, are there dementia symptoms present? And what, if yes, what stage of dementia severity, mild, moderate, or severe? I think that is generally understood what that means, and that's going to help get you, the person and family into more care and support and treatment and resources. And then, I did 2 number ones, both important. So the second one is determine the cause. Once you know there's dementia, determine the cause or the etiology of dementia. Now, that's a big topic too, which I'm going to talk about in a later talk, but that's what I would say that take home practical step is. Hopefully I helped elucidate what's the difference between dementia and Alzheimer's. There are some references. Here are some upcoming talks, and the next one is next Tuesday, Memory Loss and Aging, When and How to Talk to Your Healthcare Provider. And that third one, What to Expect During and After a Memory Evaluation. That'll get more into some of the things we talked about, which hopefully can help you or your loved ones. And then there's some information about how to contact me. Feel free to reach out via email. And I'm going to be starting in-person events in March with BrainLove in the Phoenix area, or maybe other places too, but definitely here. And then later in 2025, an integrative dementia practice. So keep an eye out for that.